Today we are going to be doing a cardiac and respiratory assessment. I'm just going to come back on this side of the bed. I'm going to be doing a cardiac respiratory assessment just so I can get an overall information of what I need. Is that okay with you? Do you have any questions? No. Okay, so I'm first going to start by just asking you a few questions. Do you have any shortness of breath or chest pain recently? No. And have you felt any excessively tired or anything? Alrighty. And do you have any history of cardiac disease yourself? Is there any history of cardiac disease in your family? Okay, so my patient is alert and oriented. They're answering all of my questions appropriately, which tells me that I am able to move on. So I'm next going to ask, do you have any cough or any cough lately? And do you use any oxygen at home? Okay, so at this time for this assessment, I won't be doing it, but I would check the vital signs of my patient. And I would know if they are within normal limits or not. So mine were within normal limits, so I'm going to be able to move on. So I'm going to start by assessing your neck. So looking at it overall, I don't see any bounding or pulsating of the jugular vein or carotid arteries. So I'm first going to just start by asking my patient to look to each side. So can you look this way for me? And I'm going to use my pen light. And can you look this way for me? Alrighty, so there was no jugular vein distension on my patient, no bounding or pulsating of that, which was both expected findings. I'm now going to palpate your carotid arteries individually on each side. All right, so on each side, these were equal, a +2 in strength, equal in both rate and rhythm on both sides, which was an expected finding. So I'm now going to move on to the chest. Do you mind if I pull your gown down? I just can't have my stethoscope. I can't listen to it as well with it on. Gotcha. Okay, so while I would be doing this, I would have the head of bed up to 30 to 45 degrees, and I would be on my patient's right side, which 30 to 45 degrees for the jugular vein distension too. I'm just going to go ahead and pull your gown down now. All right, so first, just starting to look overall, I don't see any barrel chest, which would indicate chronic COPD, and I also am not seeing while they're breathing. I'm not seeing any use of accessory muscles, which is expected for both of these. Just looking overall, I can see that as they're breathing, that the chest is rising and falling symmetrically. But I am just going to place my hands here and have you inhale. All right, and when they inhale, I would see that their chest is rising symmetrically, which is an expected finding. I would now look at the apical area and see if I can see any pulsating, which I don't, and that is expected. But then I would palpate the area and see if I can feel any gentle pulsations, which I do. Feeling a gentle pulsation is expected. If I didn't feel a pulsation, that's also expected. What would be unexpected is if I didn't feel a pulsation at all. So I am now going to move on to the cardiac part of this and listening to the heart sounds. So I would start by cleaning my stethoscope off, and I am going to start by listening to the second intercostal space midclavicular, which is the aortic area. And then I would move over, at the right sternal border, the aortic area, and then I would move over to the left side, second intercostal still, and this would be the left sternal border, second intercostal. And here I'd be listening to the pulmonic area. And then I would move down to the third intercostal, still with the left sternal border, listening to the second pulmonic area, which is also known as the Erb's point. I would then move down to the fourth intercostal, left lower sternal border, and here I would be listening to the tricuspid area. After this, I would move down to the fifth intercostal. I would move over to the midclavicular line, and this is where I would be listening to the mitral valve, which is the apical pulse, point of maximal impulse. I would listen to this for a full minute. So after listening to this for a full minute, I would note that In this spot, I heard the S1 and S2, the lub-dub sound, which is expected. If I were to hear the S3 and S4, that would be unexpected, which I did not hear. Everywhere I heard an equal rate and rhythm and pulse. The pitch of it wasn't too high, and it was good strength. So I'm now going to move on to lung sounds, again using my stethoscope. And at each spot, I'm going to allow my patient to take one full breath in and out. So I again am going to start at the right, but I'm going to start at the midclavicular, and I'm going to, I will be listening to the right upper lobe around the second intercostal. After one full breath, I would move to the left upper lobe, which is at the midclavicular line again. After here, I would move over. If I had to move the breast, I would, and I would listen to the right middle lobe, which is around the midclavicular line too. After this, I would move on to the left lower lobe, which is in line with the axillary. After that full breath, I'd move over to the right lower lobe, which is again in line with the axillary. Alrighty, so after this, I would note that all of my patients' breaths, both on the right and left right and left side, were equal in depth, and there wasn't any shallow breathing. It wasn't too labored or anything of that nature. The breath sounds were clear both on the right and left side. I didn't hear any wheezing or crackling. So these were all expected findings. So I'm just going to cover you back up, and I'm going to have you sit on the side of the bed. I'm going to come to the other side of the bed. Lower that down for you so we're in a safe position. I'm going to come to the other side of the bed. So I'm going to first start by noting my patient's posture. My patient is in a comfortable and a relaxed posture. It's not sitting in a tripod position, which tells me that they're not having any trouble breathing. And then I'm going to look at the size and shape of it. Everything looks symmetrical. I don't see any curvature of the spine, and it is again in the angle of going downwards, which is all expected. So I am then just going to put a W right here to assess lung expansion. I'm going to have them inhale. On my patient's inhale, I could note that the patient's lungs were expanding both equally bilaterally, which is an expected finding. So I'm now going to assess the lung sounds. Again, going to allow my patient to take a full breath in and out before moving my stethoscope. So I'm going to start at the left upper lobe, and I'm going to go about 3 inches away from the spine, around the C7. I'm going to listen to this for a full breath. I'm going to go to the right upper lobe, again in the same position. And I'm going to go in a ladder position, so I'm going to now go to the left lower lobe in the axillary line, but I'm just going to be a little bit further back. And after that full breath, I'm going to go to the left lower lobe, still in the axillary line. Alrighty, so all of my patients' breaths, both on the left and right side, were equal in depth. They weren't too shallow. They were clear. I didn't hear any crackling, wheezing, or labored breathing. So that was all within expected findings. I'm just going to have my patient lay back down. And I'm going to keep them uncovered so I can access their extremities. So I'm going to first start by assessing my patient's skin turgor, which I could do on the clavicle or their palm. I'm going to do on the clavicle. Their skin returned back to normal rapidly, which was an expected finding. I am now going to check my patient's extremity temperature. They are warm everywhere, which is expected for the temperature in the room. Looking at their overall skin temperature, they are pale, which is expected for their ethnicity. And I am now just going to assess for edema. The skin returned to normal. There was no pitting, which tells me there's no edema. I don't see any ulcers or abrasions, especially on the shins. and the toes, which tells me that oxygen is adequately perfusing to the lower extremities. I am now going to assess the nail beds. So I would assess the nail beds, and I would say that the nail beds are pink, which is expected. I don't see any clubbing of the fingernails, which tells me that there is adequate oxygen perfusion to the extremities. I'm now going to check for capillary refill. It is within 2 seconds on each hand, so that is also within expected limits. So I'm now going to do it here. That was also within 2 seconds, which is expected. I am now going to do the peripheral pulses. I'm going to start with my radial pulses. So I would note that each one is a +2 in strength, bilaterally equal in rate and rhythm. I would then do my tibial pulses, which are going to be right by the Achilles in this groove right here. I would note that these are also a +2. Bilaterally, they're strong, not bounding, equal in rate and rhythm. And I will now do the dorsalis pedis, which is between the first and second toe. I would also note that these are +2 in rate and rhythm, +2, not bounding. So I am now done with my assessment. Do you have any questions? All right, I'm just going to cover you back up. I'm going to put you in a safe position. Would you like to still stay sitting up? All right, so you have your call light. Since you're in the bed, and if you're a fall risk, I would put your bed alarm on and assess the environment to make sure it's clean and I don't have any fall hazards. Thank you for letting me participate in your care today. And I'm just going to do hand hygiene, and I'm going to go document my findings.